I am Dr. Tricia Hugulay. I'm a pediatric and adolescent gynecologist at the University of Colorado in Denver. I also serve as the co-medical director for our Spots and Dots clinic, which serves patients with heavy menstrual bleeding, both adolescents through adulthood. And I will be serving as your sort of facilitator and moderator today for our fourth session in a series focused on heavy menstrual bleeding in adolescents and adults and the warning signs for a bleeding disorder. And specifically today, we are going to be talking with Dr. Genevieve Moyer, who's a hematologist actually at my institution, on building a bridge to subspecialty care. What comes next after you do identify patients with a suspected bleeding disorder. A few housekeeping items. Again, I will mention one more time, please do not forget to use the chat to sign in. You will also use that a separate link at the end in the chat to do a post-evaluation survey. We use that information. It's very important to us to tailor these talks to your specific needs. And you will need to do the sign-in link and then the post-survey link in order to get CME credit. So please don't forget to do that. We also welcome you to introduce yourself in the chat, who you are, what you do, where you're from. Feel free to come off video and audio throughout the presentation when we do the live Q&A if you're comfortable with that. A few other housekeeping items. Really important to know that everything in terms of patient identifying information will remain confidential. So please be careful and mindful when you are potentially asking questions, specific questions in your practice, that you do not use any personal identifying information for your patients. In terms of the agenda, we will start with a sort of brief pre-lecture survey just to kind of get your thoughts going on some of sort of how you practice and see if we are in agreement or if there are things to learn. And we'll go ahead and do that here in just a minute. Not quite ready for the survey yet, but after the survey, we will then go through Dr. Moyer's presentation. We will then do a post-survey questionnaire, and then we're going to do go through a live case and have some live Q&A. And with that, I am pleased to welcome our speaker today, Dr. Genevieve Moyer. Dr. Moyer attended medical school and did her residency at St. Louis University School of Medicine, and this was followed by hematology oncology fellowship at the University of Colorado, where she is now on faculty. Her medical specialty is classical hematology with an emphasis on hemostasis and thrombosis. She's particularly interested in the diagnosis and management of women, girls, and people with the potential to menstruate, those with hypermobility syndromes, and those with bleeding of unknown cause. Welcome, Dr. Moyer.
Thank you so much, Dr. Hugulay. Would we do the poll now, or should I move forward with the case? Okay.
Yeah, we're going to go ahead with the pre-session poll. So this survey will come up here in just a second. And you can answer these questions. I'll kind of read them out loud, but answer them on your own, and you'll need to scroll through to answer them all. First question, please indicate whether the following statement is true or false. Factor VIII levels can fluctuate depending on patient stress levels. Question 2, all of the following are recommended evaluation steps for an OBGYN provider to perform when assessing heavy menstrual bleeding prior to referring a patient to hematology, except for one. And you can look through the options and answer what you think is best. Question 3. What should patients not be advised to do while waiting to be evaluated by a hematologist? And once you have completed those 3 questions, you can go ahead and submit your answers, and then we will share those results with you. And it looks like we definitely have some variability in our answers. Question one. It looks like we are all consistent and that we do know that fluctuate levels can fluctuate. When in terms of what maybe are not part is not part of the evaluation prior to the hematologist, looks like there's quite a variability in the responses. So hopefully something to learn from Dr. Moyer. And then what should patients not do? I think universal agreement that they should not stop taking any hormonal medication, which I also would agree with. So glad to hear that providers are not recommending that. And with that, we will let Dr. Moyer take it away.
All right. Thank you again. I'm really excited today to talk about this. As Dr. Huguley mentioned, her and I have a combined clinic for women, girls, and people with the potential to menstruate who are having heavy periods and are suspected to perhaps have a bleeding disorder. So we're kind of on the back end of this referral. And I totally recognize that there's a lot of variability and sometimes a lot of frustration and confusion of what happens before patients get to us. So the goal of today's talk is to really just help to make that transition a little smoother and help increase your confidence in knowing when a patient should be referred and what to do in that interval before a patient is actually seen for subspecialty care. So just as a little bit of a review of the things that had come up in previous echo sessions, in case you had not attended the lead up to this particular presentation, I'm assuming at this point you are ready to refer someone to subspecialty care. So you've probably already identified some concern that this patient may have a bleeding disorder. That may mean that you had performed a clinical bleeding history, and there's a lot of different ways to do that. We often will use something called the ISTH BAT that incorporates all these different domains of bleeding. That's just one way of getting to the bottom of a clinical symptom of abnormal bleeding. If you're worried about heavy periods in particular as your abnormal bleeding symptoms, you might use something like a PBAC or a pictorial bleeding assessment tool. There's a couple of different versions of this out there. This one's from the HFA website and does include menstrual cup, although that's something that is still being validated. And then the last thing that you might have done would be perform what we call a first tier bleeding disorder assessment, which is your initial screener for common inherited bleeding disorders that looks at common coags, von Willebrand factor levels, and then of course the CBC and ferritin. So I'm assuming at this point that there's something in this mix that was abnormal that made a referring provider decide that it's time to send them to subspecialty care. And then these are the things we're going to kind of talk about that can be challenging in that interval. The barriers to the referring providers, what to do in that interval before they're seen at subspecialty care, and then also what patients can do in that waiting period as well. So to start off with that first learning objective, we're going to be talking about the barriers faced by referring providers. And there's three main kind of buckets that I've broke this down to: diagnostic uncertainty, where to refer patients, and trying to know how urgent this referral is. How quickly do you need to get them seen? So starting off with diagnostic uncertainty, this addresses that very first poll question that was asked. There's a lot of variability in a lot of these coagulation factor tests that can be really difficult when you're trying to make an underlying diagnosis of a bleeding disorder. Factor VIII and von Willebrand factor activity levels in particular are known to vary quite a bit. And in fact, only 2/3 of a person's given von Willebrand or factor VIII activity level at a given moment is determined by genetics, and a third is determined by their environment in some way, with stress obviously being a huge one. The example I always like to give is of a patient that I saw that had a von Willebrand factor activity level of 20% as their baseline. Then they came in to do something called a DDAVP test, where we assess whether or not they respond to a vasopressin analog. And they got stuck in traffic on their way here. So by the time they arrived at the center, their von Willebrand level was almost 200%, just to give you an idea of how much stress can have an impact on that variability. But stress can also mean physiologic stress. So iron deficiency is one that we've identified can impact von Willebrand factor VIII activity levels, but also illness, surgery, and things like that. Obviously, hormonal status and pregnancy is a big one. Estrogen is known to increase these factor activity levels as well. A lot of our patients with heavy bleeding are on some sort of estrogen-containing medication, which can muddy the waters quite a bit. And then we know that levels also increase with age and can vary with time of day and other things as well. The other thing that can impact diagnostic uncertainty are all the pre-analytical variables that go into factor activity testing. So what we're seeing here is even if you have a consistent test from an individual patient where they're giving you their true baseline, there are a lot of things that can impact that result on a laboratory level. So what we're looking at here on the x-axis is ISTH, or International Society of Thrombosis and Hemostasis, plasma samples, like pooled known samples that contain a certain percent of von Willebrand factor activity. So from 20% up to 100, and then they sent these known baselines out to 11 different labs and compared the results from these different labs. And what you can see here is that there's wide variability in these labs, even though we know that these initial samples had the exact same amount of factor activity in them. So sometimes what can happen is inside the tube, if it takes a while for that to get processed, the factor activity protein can actually break down inside the tube and it can end up looking a little bit lower. But errors can also happen on the measurement equipment side as well that can lead to all kinds of variability. And then, of course, you can always have accidental swapping of samples, and all kinds of things can happen that can make it really confusing if you get two really discrepant set of results to know what's actually going on here. Another thing that we don't do from the hematology side that makes it any easier is we're changing our diagnostic criteria all of the time. So it used to be that in the past, if you had von Willebrand levels greater than 30, you were in this zone of low VWF that we didn't really consider a true bleeding disorder. In the last couple of years, in fact, it was in 2001, the diagnostic criteria for von Willebrand disease was changed such that if you have a von Willebrand factor activity between 30 to 50%, as long as you have abnormal bleeding as well, that also gets you a diagnosis of von Willebrand disease. And then when it comes to hemophilia A, which is factor 8 deficiency, and hemophilia B, which is factor 9 deficiency, the technical definitions at this point is anything 40% or less would be consistent with the diagnosis of mild hemophilia. And then any levels greater than 40% are still called hemophilia carriers, which I think we all acknowledge is a somewhat problematic terminology that in time it may be that we move away from, but this is really the accepted diagnostic nomenclature at the current time. If someone has bleeding symptoms and they're above 40%, then they'd be classified as a symptomatic carrier to distinguish them from someone who is an asymptomatic carrier. But I think one of the most challenging things is, we ask providers when they're seeing patients with abnormal bleeding symptoms to screen with these tests to look for abnormalities. But even in the hemophilia world where we're testing these patients, a good chunk of patients don't have any abnormal bleeding disorder tests. And we call those patients, or label them as having something called bleeding of unknown cause, which we do consider a bleeding disorder in its own right. And in fact, up to 30% in some studies of patients who referred to a hemostasis expert because of abnormal bleeding symptoms may end up in this category. So you don't have to have the right answer, is really the take-home point. Before you refer someone to a hemostasis specialist. If you have a high enough degree of suspicion, if someone is just demonstrating a lot of concerning signs and symptoms, even if you have abnormal irregularity in the laboratory testing that you're getting, that still warrants a referral. And we can do these additional tests like platelet aggregation, genetic testing to try to get to the bottom of it, or to see if someone really does fall into this bleeding of unknown cause category. So you've decided that you're going to refer someone to a hemostasis specialist. Who do you refer them to? I feel very strongly that it's important whenever it is an option to refer someone with a suspected bleeding disorder to a hemophilia treatment center or a hemophilia and thrombosis center. And this is really not just because we're trying to, selfishly capture all of these patients, or, we think that other providers can't do a good job in taking care of them, but it's really because we have additional resources that can optimally help to manage these patients. The most hemophilia treatment centers get federal funding to support certain patient services that they can get that they may not get somewhere else. So for example, included in one comprehensive visit at a hemophilia treatment center, patients get to see a behavioral health expert, a pharmacist, a social worker or psychologist, and that's not any additional cost outside of their visit to see a hematologist. So there's a lot of great benefits, and these are rare diseases. So it may not always be intuitive to someone who doesn't spend all of their time treating people with bleeding disorders what really is going on or how best to treat them. The other thing I would say is that there's increased ability to get access to certain medications, which can also be difficult, such as factor replacement therapy. Another reason to have someone at a center that's accustomed to working through those prior authorizations. There's currently 149 hemophilia treatment centers across the United States. This is a little bit hard to look at, but what you're looking at here is the stars all represent different HTCs across the country, and then the colored little dots represent the patients in their locations that are captured by a given treatment center in that region. So I don't know where everyone is coming from today, but you can kind of look at that map and get a sense of if there is or is not a hemophilia treatment center near you. The unfortunate reality is that there are some times where it's not practical to have a patient travel to an HTC if they're not nearby. So the second best option would be to have someone be seen at a academic institution by someone who considers themselves to be a classical hematologist, or I don't think there are very many, but there are some community hematologists who really specifically specialize in classical hematology. And that's to distinguish providers from those who do more oncology. Obviously, hematology and oncology is a combined specialty. And someone who's treating breast cancer and lung cancer most of their time just may not have the insights and skills and familiarity experience to optimally take care of someone with an inherited bleeding disorder. But if that is the only option, I think it is still important that someone be seen by some kind of training in inherited bleeding disorders. I think that in that case, they will usually have links and kind of connections to other providers who may help to guide that care and at least have some experience in managing these patients. Lastly, talking about how urgent is the referral, there are a couple of things that should definitely prompt a more quick referral or some advocacy on your part as the referring provider that these patients get in more quickly. So for example, if someone's having really prolonged refractory heavy menstrual bleeding that can't be controlled by the gynecologist and yourself who's taking care of them, that would be a really good reason to encourage the treatment center to try to get the patient in as soon as possible. Same thing if they have uncontrolled bleeding from other sites, or if they're anemic, just indicating that this bleeding is heavy enough that it continues to go on, it's going to be a severe problem. And then the other thing is if there's some sort of impending procedure, they're going to be delivering a baby or having a major surgery. So moving on to that next objective is what can providers do to form a bridge for patients to hemostasis specialists? So what can providers do in this interval period before they're seen by a subspecialist? Obviously, the first thing we've talked a little bit already about treating iron deficiency. I think that was in one of the previous talks, and that's super important, whether that be encouraging intake of iron-rich foods, or I sometimes like to recommend that patients use the iron fish in their pots when they're making soups and things like that, or if it's oral iron or IV iron replacement. Another thing or other things that we would have you consider to do is evaluate for hypermobility, document a menstrual history, consider a separate referral to gynecology if you're a primary care provider, and then also you can offer other educational resources to help bridge the gap. When we're talking about screening for hypermobility, this is something that we do a lot as hematologists because sometimes this can be an underlying explanation for why someone's having abnormal bleeding symptoms. But there's really nothing special that we do as hematologists to manage hypermobility per se. We just know that it can be associated with bleeding, and so therefore we take on the responsibility of screening patients and then referring them if appropriate. And that's really something that I think most primary care providers can do as well as OB-GYN providers as well, if you have that extra resource and time. So this is how we would screen for hypermobility, is something called the Beighton score, which includes looking at the flexibility of the pinky, the thumb, the extension of the elbows and the knees, and then whether or not someone can touch the floor when they're bending over with their knees straight. Because sometimes patients can get older and tighten up, and we can miss patients who maybe do have true hypermobility. If someone is 1 point short of meeting criteria, so in other words, if they're like a menstruating adult and they have a score of 3 or 4, then we would recommend doing something called the 5 point questionnaire. And if you also meet 2 of those criteria, that would be another indication that they meet criteria for hypermobility. Not necessarily EDS or Ehlers-Danlos syndrome, just hypermobility. What I do in my clinic is after I establish that someone has hypermobility, I'll refer them for an echocardiogram just to screen for any cardiac or valvular abnormalities. And then their follow-up visit, I'll perform these secondary assessments. And if they have any abnormalities on these things or concerning family history of things like vascular rupture or hollow viscous rupture, then I'll refer them to a geneticist for a formal diagnosis. I don't know that that's something that is absolutely critical to be done by every primary care provider, but if you're trying to facilitate the evaluation, especially for someone with bleeding of unknown cause, this is a really helpful thing that can be done. Another thing would be to document a menstrual history and the different types of menstrual suppression that have been used in the past. These are some of the questions that we would ask in our clinic, would be the age at menarche, how periods have changed over time. That's particularly, I think, helpful in older individuals, people who have had children. How frequent are their periods? In other words, are they having regular monthly periods? How long does the period last? The change in sanitary devices over 24 hours, whether they're bleeding through clothing and bed sheets, passing clots, or if they've ever needed iron replacement therapy. One way of doing this is with a PBAC that has been mentioned before. And like say, this is the one that is utilized by the HFA and is on their website. The way this works is a patient would put a hash mark for every one of these devices that they use. So for example, if on day 1 they use 1 light pad, they'd get 1 hash mark, and you can see the key over here that would give them 1 point. If on day 1 they used 3 heavy pads, then you'd put 3 hash marks, and for each one they'd get 20 points. So that would be a total of 60 points for that day. And you total the whole weeks or the whole period up to get your final score, with anything over 80 being consistent with heavy menstrual bleeding. In terms of the other educational resources that can be offered to patients, the HFA website does offer a lot of really wonderful resources, a lot of things that I've referred to my patients in the past, a lot of things that patients can go through themselves to work through, and providers can actually print off and have available for their patients if they have heavy bleeding or in that bridge period. A lot of good links to websites that offer reliable information and resources on mental health resources. A lot of really good educational videos, podcasts. Some of these podcasts are ones that I've definitely recommended my patients listen to, and I've listened to myself. And then also for the more research minded, there are some really good citations on there too, if patients are interested in reading source material. And lastly, what can the patients do before they see a hematologist? It's obviously a very high anxiety period where they are worried now that they have maybe a bleeding disorder or they have bleeding symptoms that are unexplained. What can they do to help alleviate that stress of that interval before they can be seen? These are a couple of examples. And the first one would be obviously to utilize those resources that are being provided by the referring provider. They can, do these PBACs themselves at home, use some sort of long-term period tracker, and there are some options online as well. A lot of different options out there that are all really good. This one happens to be very closely derivative of something that we've used kind of more in the clinical setting, but any of the online apps can be really helpful, especially to determine regularity of periods. And it's nice to bring that in, and kind of helps us cut to the chase a little bit quicker when we do see them. Also on the HFO website are links to these different bleeding questionnaires that I think are helpful for patients to really get a gauge of whether or not their bleeding symptoms are actually abnormal, because it's not something, especially periods, that we talk about a whole lot. It can be hard to know sometimes if the things that you're experiencing are normal or if they would be worrisome for a bleeding disorder. Other things would include discussing family history. So that's really important. A lot of times we'll have patients come in and say, oh, I don't know. I think that maybe my paternal cousin has a bleeding disorder, but we don't know them very well. And if that's hemophilia, that could be a really huge clue of what is going on in that patient's history. So trying to get that kind of pedigree established ahead of time can be really useful. And then just generally making a list of questions as well so that you're prepared when you come in to see a doctor. There's a lot of nerves that can come along with that. It's really easy to forget all the good questions that you may have had if you didn't have them written down. And then it's always nice too, if you have time to check in with insurance, ask about restrictions and where you can be seen in labs. Those are usually things that can be overcome because of the subspecialty care that's provided at a HTC, and something that we can help sometimes work with patients beforehand and should not be an overall barrier to care as long as we have enough time. All right, so that is brings us to the post-session poll. I think the last thing I'll say before I turn it back over to Trisha is obviously there are lots of these centers and specialists out there, but really not enough for the number of patients that are out there in the community, especially as we're identifying more and more potential menstruators with inherited bleeding disorders. I think that there is an inevitable wait time that will accompany that. That might even be a couple of months. And so while we wish that weren't the case, I think at these centers, we do our best to try to get people in as quickly as possible, but these gaps are inevitable. And so I hope that this helps to know what are some things that can be done in that inevitable wait time.
Thank you, Dr. Moyer. That was a wonderful overview. And I have to say, I particularly appreciated your point about the educational resources you can provide to patients and sort of setting them up for success in terms of going to their family history. Those are things I don't always do. So I'm definitely going to take those with me from your talks. I think they're extremely worthwhile. So thank you. So with that, we're going to put back up that poll that we started with and see if any of your answers have changed. So again, question 1, please indicate whether the following statement is true or false. Factor VIII levels can fluctuate depending on patient's stress levels. Question 2, all of the following are recommended evaluation steps for an OBGYN provider to perform when assessing heavy menstrual bleeding prior to referring a patient to hematology, except for one. What is that one? And then question 3, what should patients not be advised to do while waiting to be evaluated by a hematologist? And again, once you have those completed, you can submit your responses. And again, now is a wonderful time that if this sparked any questions, maybe not even necessarily questions because we have a fair amount of time, questions that weren't necessarily addressed in the presentation that you're curious about or relate to your own practice, feel free to drop those in the chat. So looking at our post survey, Dr. Moyer, wonderful presentation. You now have uniform agreement for all 3 questions. Yes, indeed, factor VIII levels can fluctuate. Question 2, yes, we really want to reserve the platelet aggregation studies for the hematologist for a number of reasons, as Dr. Moyer pointed out to us today, and definitely keep patients on hormonal medications. We can get that testing done even in that setting, and we really want to keep these patients under good control, especially since a lot of the patients unfortunately do sometimes have to wait a bit for that referral. And this concludes our lecture today and our series. We really appreciate you engaging with us today and hope this gives you some useful tools as you treat your patients. So thank you again for joining us today and have a wonderful week.